still compromised. So, and second is again re-evaluation of ventricular function during recovery. The first evaluation in when the patient comes to. The second evaluation when we have to re-evaluate whether the patient has responded to the therapy or not. So echo you have to repeat when the patient is getting discharged. And third is the assessment of ventricular function after revascularization. Revascularization is when after medical treatment and putting a stent or an angioplasty, whether the myocardium has recovered or not, or whether it is still damaged. So this is what are the indications. The class 1 and 2A, both are important. Whether to, the echo is very, very important just to re-evaluate the patient. First on the admission day, then the treatment and the revascularization. So what are the pathophysiology of coronary syndrome? Normal LV motion consists of simultaneous wall thickening and endocardial relaxation towards the center of the cavity, so that the cavity decreases in size and symmetry. So normally what happens, the myocardium, there is a thickening, then there is augmentation of the thickening from 9 to 11 millimeter to 14 to 16 mm. So that means there's a change of 35 to 40% change in thickness. So several layers of myocardial fibers that contract in ringing fashion, right? So this is what the areas looks like. So this is the area which is supplied by the right coronary artery. This is the RV on the left side. This is basically the short axis. I have showed you previously, this is the short axis. Short axis is of 4 parts. Next time I'll try to get the video recording. Then RV on the left side and right side is the left ventricular cavity. This is what the normally it looks like. Ischemic cascade. So what happens? A well-defined hierarchy of functional abnormalities develop as a consequence of interruption in coronary blood flow. So what happens? This is what the normal myocardium. Then what happens? There's a perfusion abnormality, means the blood supply to the part is reduced. Then first of all, there's a diastolic dysfunction. Then there is a strain abnormality. Then visible abnormal wall motion abnormalities are there, which is seen in the ECG as well as the echocardiography. Then at the end, there is the scar, which is sometimes reversible or sometimes irreversible. So this is what happens when the pain is there. First of all, we have to see the ECG. Then we have to go for an echocardiography. We have to see the diastolic dysfunction. That is what filling abnormalities shows. Then there is regional wall motion abnormalities, which is known as the contraction part. Then further is the relaxation part. So as soon as the coronary artery occlusion is there, the diastolic abnormalities occurs first. That I will show you how it looks like an echocardiogram. So wall motion abnormalities like loss of systolic wall thickness and decrease in endocardial excursions in the region perfused by obstructed coronary arteries. If obstruction persists for more than 4 hours, myocardial necrosis ensures and a persistent wall motion abnormality develops. So basically, the first 4 hours of the chest pain is the most important. And within this time, if you can open the artery and revascularize the myocardium, the patient will survive. Other patient will leads to the fibrosis and the end damage of the myocardium. If flow is returned before the onset of myocardial necrosis, viable degree of recovery of function is expected. The severity, nature, and the extent of wall motion abnormalities depend on the amount of transmural and non-transmural infarction. So what is myocardial stunning? Myocardial stunning and hibernation is a very important topic you have to know. Stunning is basically shock, astonish, so that temporarily unable to react, knock unconscious or in a semi-conscious state. So stunning is basically the semi-conscious state, which happens in a myocardial. Myocardial stunning after a severe acute ischemic insult. A brief period of severe ischemia may produce prolonged myocardial dysfunction. with gradual return of contractile activity. In this case, acute ischemic result occurs, but after the treatment, it returns to the norm. So this represents a persistent regional dysfunction at the time when chest pain is there, last segment deviation is there, and regional perfusion have recovered. So slowly, but it recovers automatically. But it may take days also, it may take hours also for the regional motion abnormalities to recover. So improvement of ventricular function occurs gradually over the course of days to weeks. Generally, mechanism is the generation of oxygen-derived free radicals, calcium overload, decreased sensitivity of myofibrils to the calcium. So these are the mechanisms due to which myocardial stunning occurs. What is hibernation? Hibernation is the Latin word meaning spend the winter in a state like deep sleep. So impaired resting LV function due to chronically reduced blood flow that can be restored by revascularization. See, stunning can recover on its own, but hibernation is a part in which if you don't, just hold on. Hello, ma'am, good evening. हाँ जी मैम, good evening मैम. हाँ जी, हाँ जी, हाँ जी, हाँ जी. इसका हाँ जी, हाँ जी, लेफ्ट का फिंगर बहुत देर से हो गया, बहुत देर से. मेडिकल लेफ्ट है राइट है मेरे को एग्जैक्टली बोल गया. वो मेरे को डॉक्टर जतेंद्र ने लिखा होगा ना, अभी जाऊंगा ना फिर आपको बताता हूँ मैं. नहीं, रूमेटॉइड आर्थराइटिस है, आईडी. फीमेल 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 फीमेल, हाँ जी. शायद नहीं, उसी की वजह से एंटीडायबिटिक पे है. होगा होगा, हाँ जी, हाँ जी. हाँ जी, हाँ जी, मैं दोनों चीजें हैं, दोनों चीजें हैं. ठीक है, राइट. ठीक, ओके, ठीक है, ठीक है. थैंक यू, थैंक यू. ओके, sorry for the delay. So hibernation is the Latin word meaning spend the winter in a state like deep sleep. So impaired resting LV function due to chronically reduced blood flow that can be restored by revascularization. So in this, you have to revascularize so that the LV function return to normal. But in stunning, it can return to normal after a few days. So hibernation represents a condition in which myocardium reduces its contractility and hence its oxygen consumption to match reduced perfusion, thereby preserving cellular viability. So hibernating myocardium recovers after revascularization, but not in the case of stunning. Stunning recovers on its own, but it may take some time. So these are the, in this chart, you can see uh, what is stunning, what is hibernation and ischemia. So in, you can see the coronary blood, the myocardial mechanical function is reduced in stunning. Hibernation, again, it is reduced. In true ischemia, again, it is reduced. So coronary blood flow and post-ischemic is normal or high in stunning, mostly reduced or low normal in hibernation, and mostly reduced into ischemia. Myocardial energy metabolism, harmful effects of fatty acids, fuels versus glucose is there. In hibernation, it is reduced or low normal, and in true ischemia, it is reduced. So duration, hours to days, it will take maybe weeks, and days to hours to months in hibernation. Because sometimes patient might ask you why the patient is taking a lot of time. You have revascularized the patient, but it's taking months to recover. It may happen in hibernation. And true ischemia takes minutes to hours, then later maybe days. So outcome, full recovery in stunning, variable recovery if revascularized. If in ischemia there is myocardial necrosis there, if severe ischemia persists, then it is totally damaged. Right? So markers of viable myocardium, just for diastolic wall thickness, again echo, alternative is CT MRI. For systolic wall, again echo, and alternative CT MRI, and gated SPECT. Regional motion wall abnormalities can be seen by echo, and alternative is CT MRI. For regional blood flow is SPECT or PET and MRI. Myocardial metabolism, PET. Cell membrane integrity, again SPECT. And contractile reserve is dopamine or echo. So assessment of wall thickness of dysfunctional segments. If segments are preserved, the normal myocardial fiber reversible dysfunction caused by acute ischemia, swelling, or hypercapation may be the possibility. But if preserved, mixture of scar tissue and myocardial fibers, maybe they can lead to irreversible. But if it's obviously the thickness is reduced, then it may be due to post-infarction scar, which can lead to irreversible dysfunction. So what is myocardial tethering? Tethering is tie with the tether. So tether is a rope or a chain used to tie an animal to a fence. So tether also means restraint. So myocardial tethering refers to the impact that an abnormal segment has on a normal adjacent border segment. So thus the extent of wall motion abnormalities often overestimates the anatomic extent of ischemia or infarction. Tethering occurs both horizontal and vertical. So basically, when one part is damaged of a myocardium, the normal part also sometimes look damaged, but in fact, it is not that. So it overestimates sometimes the echocardiography. So horizontal tethering, it occurs when there is akinesia or dyskinesis of a segment, which results in the reduction in endocardial excursions in the adjacent functional normal boundary tissue. The wall motion abnormalities is overestimated because the detected wall motion abnormality includes not only the infarcted, but also variable percent of immediately adjacent boundary tissue. So generally, the wall motion abnormalities is overestimated approximately 15 to 20% due to this effect. So vertical tethering, this contractile abnormality is in the subendocardium, has a disproportionate impact on overall wall thickening because normal contraction is heavily dependent on endocardium rather than epicardium contraction. In general, ischemia and infarction of inner 20% of myocardial wall result in frank akinesia or dyskinesia of that segment. Non-transmural involvement result in malfunction of entire wall thickness. Thus, wall motion abnormalities is indistinguishable from that seen with the full transformal infarction or ischemia. So, what are the causes of wall motion abnormalities? Why? What happens? Why the contraction of the heart reduce? What are the causes? Infarction is one of the main cause. I told you because the ischemia, blood is not going to the myocardium. So cardiomyopathy can be the cause. Myocarditis can be the cause. Left bundle branch block can be the cause. Hypertension or afterload mismatch can be the cause. Hibernating myocardium can be the cause. Stunned myocardium can be the cause. Toxins, example, alcohol can be the cause. Postoperative state can be the cause. Phase rhythm can be cause. Right ventricular volume or pressure overload can be the cause. Wall motion abnormalities during stress also can occur due to ischemia. Translational cardiac motion, marked increase in the blood pressure, cardiomyopathy, and rate-dependent left bundle branch. So, what are the other causes like methods for evaluation of regional motion abnormalities? So, visual method like descriptive, like normal. So, what happens? Normally, the heart looks normal. But when you are doing an echocardiography, the first weakness which is seen is hypokinesia. Then there is akinesia, then dyskinesia, then at the end, it's a scar. So dead tissue, basically. So these are the grades. Start from normal, hypokinetic, akinetic, and dyskinetic. This is how we diagnose the wall motion abnormalities in an echocardiography. So location can be anterior, also anterior part of the myocardium wall, lateral part, inferior part, posterior, apex, basal, mid, apical. So another method is WMSI method. It's normal is grade 1, hypokinetic is grade 2, akinetic grade 3, dyskinetic is grade 4. Then after it's a scar or dead tissue, right? So assessment of ventricular geometry. The normal geometry of left ventricular in apical four-chamber view is bullet shape with gradual tapering of diameter towards the apex. In short axis, normal LV geometry is circular. In parasternal long axis, the geometry involves slight concave curvature of both septum and inferior posterior wall. So normal versus abnormal, you can see. The left side is the normal geometry. You can see this is the short axis. You can see the uh, part which is supplied by the right coronary artery, left is the RV, and in between you see the LV. The upper part is the anterior descending, the middle part is the left circumflex, right? And on the right side, it is due to the wall motion abnormalities, it has become little large and deformed. So this is the normal LV geometry. Parasternal long axis, you can see the RV, OT, normally how it looks like posterior wall, intervertebral septum. So parasternal short axis, how it looks like, an apical four chamber, how it looks like, an apical two chamber, how it looks like. This is the normal LV geometry. So abnormal is rounding of the apex or asymmetry of the apical shape as opposed to smooth bullet-like shape. Mostly the LV is bullet-like in the apical four chamber, but it becomes rounded because of the akinesia or hypokinesia. Regional dilatation of the LV wall sometimes happen when supply to the LV is reduced. It is important to quickly access the LV geometry because it often provides a very rapid clue to the presence of normal regional wall function. So this is what happens normally. This is the LV in the apical four chamber, the apical view. What happens when there's an aneurysm formation? So this is aneurysm dilatation. When there is a regional dilatation, this is how it looks like. So short axis also, normally it looks like when there's regional dilatation septal area, then regional dilatation of the lateral area. So schematic representation of the 17 segments of LV parasternal long axis view. So the basal anterior septal, this is the upper part in the IVS area. Basal anterior septal, this is how you diagnose, how you give a report, which area is infarcted. Mid anterior septal, and down is the inferior part, basal inferior lateral, this mid inferior lateral. So this is apical four chamber view, the LV part. So here also, the first one is the basal inferior septal, then basal inferior, then apical septal, then two apex. Two apex is just the pointed part. Then apical lateral is the lateral part, mid anterior, lateral, and basal anterior lateral. This is how you classify the different parts of the LV in apical four chamber. This is short axis in which you can see the basal anterior part, right? Basal anterior septal part, right? And then you can see the basal inferior septal part, the basal inferior and basal inferior lateral, and the basal anterior lateral. So again, the same thing which I told you previously, the grades. Normally, the echo, the myocardium is normal. When it's abnormal due to ischemia, first of all, there's a hypokinetic segment, then it's an akinetic segment, and then dyskinetic, and later at the end, aneurysmal dilatation. This is how you score it. Normally, it's grade 1, then mildly hypokinetic, then hypokinetic grade 2, 2.5, then severe hypokinesia, then akinesia grade 3, dyskinetic grade 4, Aneurysmal is 5, 6, and 7 is akinetic with scar, then dyskinetic with scar. So wall motion score index is basically from 1 to 5 to each segment, and the total score is divided by the number of segments evaluated to create a wall motion index score. A ventricle with completely normal wall motion would have a score index of 1. Higher score represent great degree of ventricular dysfunction. This global score can be subdivided into anterior score, representing on the distribution of the LED territory, and posterior score depending on the right coronary plus left coronary artery. So anterior apical MI, what all the areas are affected. Then if there is a inferior wall MI, what all areas are affected. When wall motion abnormalities, when you are describing one and dealing with coronary artery disease, the location of wall motion is predictive of the location of coronary culprit lesion. So coronary culprit, if the left anterior descending artery is involved, so it will affect the anterior area, the septal area, the blue bar area, which is the septal, the mid-anterior septal, mid-septal, right? When it is affecting the pink area is the basal septal and basal inferior. That is the right coronary artery. The yellow area is the circumflex. That is the lateral part. The mid-lateral, the mid-posterior, basal posterior, and mid-lateral and basal lateral. So this is by the left circumflex. So basically there are left coronary and the right coronary artery. And left is further divided into left anterior descending and right and left circumflex. So, and right is right coronary. So right is basically the pink part, and these are the areas which is supplied by the right, and the blue part is by the left anterior descending, right, and the yellow part is by the left circumflex. So Doppler evaluation of coronary artery disease, left ventricular systolic function determination by interrogating left ventricular outflow tract or ascending aorta, and recording the time velocity integral that is directly proportional to the LV stroke volume. This can be successfully tracked during the course of acute MI to determine the degree of impairment, recovery, and effect of interventions. So this is what the left ventricular outflow tract looks like. And if you can see example of determining the left ventricular outflow tract stroke volume using the methods, you can see the parasternal long axis in which the left ventricular outflow tract can be measured. And then you can measure the left ventricular outflow tract integral. So patient with normal cardiac function, it looks like this. The left ventricular outflow tract integral is 27 centimeter, but patient with cardiomyopathy, the ventricular integral is less, that is around 10 centimeter. So whenever there's an ischemia, the first things which start with ischemia is diastolic dysfunction. So how the diastolic dysfunction seen in, I told you whenever we are doing an echocardiography in the introductory lecture, there is, when we are putting the pulse wave Doppler on the mitral valve, you see the big E and A. Usually in a normal diastolic function, the big E is larger than A. But in diastolic dysfunction, E goes down, A goes up. And similar thing we see in a tissue Doppler imaging. The E dash will be larger than A dash. That comes below the baseline. But if A dash becomes larger than E dash, then it means that diastolic dysfunction. So this is what the graph shows. So mitral inflow velocity, when we are putting a Doppler on PW, pulse wave Doppler on the mitral valve. So this is how normally it looks like. The E wave is bigger than the A wave. But when there is grade 1, the E wave go down, A wave goes up. Grade 2, there's a pseudo normalization. Again, E goes up, but A's goes down, it is pseudonormalization. But when there is grade 3 and 4, E is much bigger and A is very small. So this is diastolic dysfunction. So if you do with the mitral annular with the tissue Doppler imaging, you see normally E dash or E prime, E A prime or A prime, the second line. If you see that E dash is bigger than the A dash, but when A dash become bigger than the E dash, then it is diastolic dysfunction. We can do with pulmonary vein flow also. Okay. So at the time of acute ischemia or MI, there is immediate reduction in LV compliance, resulting in reduced EA ratio with prolonged deceleration time. EA ratio becomes less. Presence of restrictive pattern or even normal pattern of mitral inflow at the time of acute MI represent high risk subset with substantially worse prognosis than the patient with delayed relaxation. So normal mitral inflow confers a poor prognosis, suggests that this is a pseudo-normal pattern rather than a truly diastolic property. So pseudo-normal pattern is seen, that is grade 2, which I showed you before. Poor ventricular compliance, more extensive MI, elevated LV pressure. So detection of classic restrictive inflow pattern does convey the adverse prognosis, irrespective of the presence, nature, and degree of previously existing underlying abnormality. So this is how the diastolic dysfunction looks like in a graph when we put a PW Doppler on the mitral valve. So even E becomes small than A, it is diastolic dysfunction that is seen in the A1, the upper left one. So when it becomes a restrictive pattern, it is seen in C. You see the E is more and A is very small. It is restrictive pattern in diastolic dysfunction. And in B, you see the normal pattern. The E is little more and A is little less. So B1 is the normal pattern. The A1 is the grade 1 or 2 diastolic dysfunction. C is the grade 3 and 4. That is the restrictive pattern when diastolic dysfunction becomes more. So Doppler tissue imaging, I told you, through which we can do the diastolic dysfunction. The accurate one, the E dash and A dash, I told you. That targets the tissue rather than the RBCs, as in the conventional Doppler study. With this technique, either the myocardium or the fibrous skeletal tissue of the heart can be targeted. So Doppler tissue imaging can be displayed as a color display, saturating the typical anatomic structural information. So this is, we can do a tissue Doppler imaging. We can take a 4-chamber view. We can take a parasternal long axis view. We can see the M Doppler view. And just you have to put the PW cursor on that. And either what we do here, we do 4-chamber view, put a tissue Doppler imaging, the color part will come, and we put the cursor on the anterior mitral leaflet. Then we see this view below the baseline, E dash and A prime. Here you can see the E dash is smaller than the A dash. So this is diastolic dysfunction. But if it is normal, the A dash will be bigger than the A dash. So this is what are the areas. We can use the lateral, septal, anterior and posterior areas of the apical 4-chamber view. So here they have taken the septal area. We can take the lateral part of the LV. We can take the septal part of the LV. We can take the anterior mitral leaflet, and we just put the pulse Doppler on that, and then we see these values. So S prime is the systolic velocity, and then there is a E prime, then there is a A prime, right? So basically, if E prime is smaller than the A prime, it is diastolic dysfunction. But normally, E prime will be the bigger than the A prime. Okay, so we'll take the class up till here. The next, with the videos, I'll bring the rest of the echocardic evaluation, and I will show you some videos in which there is MI, if there is any cardiac regional motion, wall motion abnormalities. First of all, I'll make some videos of the normal views, which I discussed with you in the first lecture, how the normal views look like, what are the various four views of the short axis, parasternal long axis, apical four chamber. Then we'll come to some abnormal videos of coronary artery disease. We'll finish the next 50 slides in the next lecture with our videos. Thank you.
Kindly drop your questions in the chat box. We'll do our best to answer them.
एक मिनट बताना वो ना ये स्लाइड उनको भेज दो यही बारी जो कर रहा हूँ आ जाओ
We'll be dropping the registration certificate registration link in a meanwhile. Kindly drop your questions in the chat box. Yes, Dr. Shweta will be dropping the certificate link in a while. Doctor, we'll wait for 2 more minutes. If there is any questions, we would be answering them.
Yeah.
Thank you, Doctor. Thank you.
हाँ मतलब स्लाइड 50 मैंने कर दी 50 रह गया नेक्स्ट में हमको वीडियो की मैं वीडियोस थोड़ी सी बना देता हूँ वीडियो पे हम भी डाल सकते हैं वो करते हैं यूट्यूब चैनल शुरू करो ऐसी हाउ टू रीड हाँ जी वो क्लास चल रही थी है एक मिनट करता हूँ
I guess there are no questions.
I'll try to send Gagna.
Yeah.
Can you send me the email on the WhatsApp on which I can send the whole file? I'll try.
Sure, definitely. I would share you.
I'll try to send the whole slide to you.
Sure.
Yeah. Shall I?
Yes. Thank you all for joining us today. We hope you found this webinar informative and valuable. If you have any further questions or would like more information, please feel free to reach out to us. Additionally, I have already dropped a link in the chat box for you to fill out and submit to receive your certificates of participation. Don't forget to follow us on social media for updates on future webinars and events. Have a great evening.
Thank you.
Thank you.